okay to do it. Let's do all the pawn moves here. Okay? And,
I didn't mean to steal this the
single
best
hand
angle.
contact. Single hand contact. You're doing from T3 to L3 with what? Superior hand. In single hand contact, you're contacting the spinous process or the transverse process. Because the spinous process, if you find what you're looking for, let's say we're doing, so with respect to if I say T1, you're going to say, John, could you lift up your head, please? And that would be C6, so this is C7, T1, and T2. If you're doing T2, then you're going to use what? The inferior hand. Contact point is here. I want to see you go on it this way. You're on the spinous process. And what do we have a little bit? Left and inferior. So this is it. This is for the inferior hand. That's we're going to use this here and here. L4, L5. The rest from here to here we're using this hand. So let's do it. Just say we're doing T6 again. Let's talk about T6. Here we are at T6. So this is T6. I want the spinous contact. This is the hand. That's the contact point. You're on it. For some of you do this, but it doesn't really matter to me. It's always good to have it across because then you're hooked onto the spinous process. So you're on it, and this is it. Direct. Little bit off. I to S because of this. So this is going to go all the way this way. That's single hand contact on the transverse process. Single hand contact on the mammillary, not on the transverse process. This was on the spinous process. Now on the transverse process, what direction you stand? If it's a PR, I'm going to be where? The left side, the side where the transverse process is high. So I'd like to see you pop it. Now, T3 to T4. How many spaces?
2.
T5 to T8.
It's this. It's 1. 1 through 4 and 9 is up. Up 1. So 5
1
through 8
through
is
4
up
is
2.
what?
T1 through 4 and 9 is up 1 spine.
Now we're talking about spines or spaces.
Spaces.
You learn 1 through 4 and 9 is up 1 spine. 5 through 8 is 2 inner
Spaces.
spaces.
2 spaces.
And then the rest is up 1 spine.
So
Actually, I
if
think
you,
it's just 1 up space. Yeah.
some of you use spaces, some of the spinous, but I just want you to know where you are. So if you find this is a spinous process, you'll come up, and here we are. So we're on this one right here. Again, is a superior hand. Your contact will be this. Now it's not this. It's this. So you're not across, but you're on one side like that. This is where we lift and go down. I may not see that, but I'm believing that you're doing it. So that's from, this is when you use a superior hand. When we come to L4 and L5, what do we use again? Inferior hand.
And you're always on the same side.
Where the spine is, if you're on the transverse process, you're on the side where the transverse process is higher.
Okay.
In the spinous process, you're on the side of laterality of the spinous process. Okay, then, so that's for Gonstead single hand contact formula. If you do diversify, not diversify, the cross pisiform, where do you stand?
On the side of the high TT.
On the side of the,
High TT.
so that's opposite the spinous process. Again, the same thing. Now, this one changes. Let's say, John, let's see whether you're subluxated together.
We can do it.
There we are. So we are here. Now, I'm not going to go this side, but he's subluxated here. So if I was going to adjust, let's say this was the high TP. This is the inferior hand goes here. On the high transverse process, this one comes here. So I want to see this. I want to see this L formation. If I say it's P L, I. That means what?
You'd be on the opposite side.
I'm on the right, I'm on the wrong side.
So
Should be-
PRI.
So let's say PRS. Let's say PRS. So my top will be what?
Clockwise.
Which is this.
We're gonna have to roll in, or not roll in, but.
Yes,
if
you're right,
PRS,
roll in,
you
yeah.
have to-
So you have to see you do this,
yeah.
and then this one is just, and then that's for the cross pizophone. The other moves you can do with this is what? L, lateral, what do we call it? LLS, slip, power slippage, where you hook.
Side slip or whatever.
Yeah, where you hook, so where you're going to be, if it's a PR, that's on this side, because I want to hook it in, and some of you have got pretty good hands, big hands, that's okay, I'll understand. And you can do this, or you can do that.
I don't know that. Yeah.
Yeah,
What's that one called?
You sit down.
LSS.
The side slip.
that's like side slip.
You just
Yeah.
do opposite the spinous and pull back.
Yeah.
Are you gonna tell us which move to do, or are you gonna say adjust the PR?
No, I'm going to tell you the move. Tell you the move and the listing.
Either
Yeah.
one on there, right?
The other thing that we can do in this position will be, could be thumb move. The thumb move goes to T1 to T2. So if I say PL thumb move, this is it. If I say T1, you're going to set up on T1. And where do you ask the patient to turn the head to?
To the other way.
To that. So you turn your head this way, use stabilization, just above. And I want to see the move. So this is not right. I want to see the move. You're moving this thing that side. So I'm not so much in the details of what you're doing. I just want to see you can move that thing that direction. If it is modified, you stand opposite side. So I'm going to stay this way, and I'm going to use this.
Sorry.
And this comes here, Tanya. So I'm going to go more this way because I need that leverage, and then that's the move I want. Could be thumb or could be pizophone. What else can you do here?
Double phenyl.
Double thinner. So double thinner, where do you always stand on double thinner?
Same side.
Same side of spinous, not right. Please remember that.
I thought there were two ways to do it. Same side of the spinous?
Yes.
Remember there was like a one
There's a
side
single
opposite
phenol.
the high.
No,
There's
the
a
only
single
thing is
thinner
that you
too.
turn when you, there is single thinner and double thinner. Double thinner, you always stand on the side of laterality. Always. So the only time you pivot this way is when you're doing L and L5. Everything else is this way.
And you're still on the same side of laterality.
Still on the
even
same side.
Okay.
Still on this, it's only the pivoting that's going to change.
Okay.
Stay on the same side of laterality all the time. So let's say we're doing an L3. You can do this and tell me this is L4. You don't have to tell me, but I will know that's L4. So you go up to this and you set, which one do you set on first?
Yeah, you're
Which is going to be where?
opposite.
Opposite, that's where this power is. So this is, we're going to set on this one. And then you're going to set on this one. I know you know that this is supposed to be 80 and this is supposed to be 20. So I'm not going to ask you to say that. But I may ask you, what's your line of drive? What's your line of drive? P to A and slightly I to S. If it was L3, it will be directly straight.
But you said L3.
Oh, did I say L3? Okay. So that'll be straight down. If you come to L4, now we go this way, and it's going to be a little bit S to I because of this.
And you're contacting the mammllaries,
We contacted the mammillary.
and that's a double thinner.
That's a double thinner.
Okay.
If it's a single thinner, now that's different because we want to go to the side where the mammillary is, and that's where we're going to stay. So now there, you're just going to use one side of that side. You're really going to put a lot of weight onto that side. It's no longer 80-20. You're going to put all your strength on the side where there is the higher thinner. That's what we contact. That's a single thinner.
You still actually put both hands down,
Yeah.
right?
But you don't. It's no longer 80.
Right.
The other one is just more of a stabilizing. When we do double thinner, it's almost like you are putting a little bit of little bit here. But when you do a single thinner, everything is going here. This is just stabilizing.
Okay.
Yeah.
The scoop moves and they also single clean.
The scoop move it's all right. The scoop is more of just how you lift it and set it. So you can do that for single hand contact for gun step.
I mean the one on that you say is square stance and you on the TP or Maserati.
So like
You have a new hand and a hammer hand.
that's single hand contact gun step. Is that what you're saying? Or is that
Yeah.
different?
Yeah, that's what I was saying.
Yeah, that's that. You stand on the side of the
High.
high mammillary and you put all your weight onto that single. So if I was doing a transverse forces here and I was going to do single hand contact, it's this, but the scoop actually means I'm going to put here and then I'm lifting. If I was to go in slow motion, it's something like this. Then. So it's almost up and in.
Yeah.
You're
There
lifting
was
it up
one
and
like where you actually turn your hand.
Let's not worry about that one.
You actually don't scoop this way. You do this and then set it. I wish I had a spine. It's fine. Can we lie that guy down or he's tied to that?
And just out of here, are we doing like one cervical, one thoracic,
Yes,
one lumbar, or
yeah,
one?
ASR. So we know it's where.
To the right.
What I want to see you do is to be able to, first of all, find what you're looking for, which is there, and then bring this
Posterior arch contact or TP contact?
TP contact, and this is the contact.
Oh, we're doing
Oh.
the thumb there.
Yeah. So you're bringing this way, and I'm interested in looking at the rat hole. So I'm not going through all the details, but I'm really interested in when you're said and done. I want to see the stabilization. I want to see the contact, and I want to see the readiness to move the TP. Now I know you're not 100% good, but I'm able to see what you're doing.
Is it just lateral flexion?
It's just lateral flexion.
Yes.
No rotation.
If there's a rotation, there will be very slight rotation.
But that's the correct for the anteriority, posterior.
Yes, but this one was just straight ASR. So if it's a spinous contact on C3, you're going to go to the tip of the spinous process, and I really want to see you do this to the patient. I'd like to see you hook at the spinous process, and then bring it in, and you should, the way we teach you should never release this. What you do, you simply roll it, and then you are again, and this is what I want to see. So that's C3.
Oh, C3.
C3 is spinous contact.
Okay.
Spinous contact.
So you contact the opposite of lateral.
No, the side of laterality. That's
Spinous contact.
spinous contact. The spinous contact. Yes.
So what listing was that?
That was PR on C3.
Okay.
So that's what we're going to do. This I'm not going to test you on the occiput.
Okay.
Okay? But you do know, you know where to contact with this occiput coming in this area.
Yeah.
So we're not going to do that.
What did C2? What did C2? Was C2 all LPJ contacts for this?
You can do lump injunction on C2.
Could you do
You can do
spinous?
spinous contact.
But there's no TP for C2, was there?
No, I've never seen TP.
Okay.
See the chair?
Yeah.
No.
Okay.
Do you want to hold that?
No, I'm just making sure.
Yeah, no.
All right.
Okay, so then we can do diversify. So go ahead and lie on that table so and face that. Or should we use this guy here?
How do you hook for the spinous? The spinous contact?
From here onto the lump.
From the spinous.
And then you are flexing the patient. And then you line up
Lateral
right.
flexion.
Yep. Then you just move it.
Yeah, you
We were taught to rotate
You rotate.
and then
Move them away.
It's more of the lateral flexion than the rotation. I don't want to see much of this.
Okay.
I want to see more of this. And when you begin to practice, you probably find it much easier when you rotate it, not when you flex the patient. It's safer for you also. Because with less rotation, injuries are very rare if you're not rotating the patient.
You really
So Lampin junction, contact it, flex the patient, stabilize, and adjust.
And
Dr. Kenya,
what
this
was
is
that
how
listing?
we were shown. Andrew, lay down real quick. I just want to see what
Yeah.
your take is.
So I come on this way. I'm right on it. You feel it? It's tender. So I'm going to do this a lot. This is way out. I'm not going to do a lot of, oh.
Did it just move?
I didn't mean to adjust it. But that's, once you're on it, with a good flexion, it doesn't take much strength. Contacts. We're going to the side of spinous laterale. So go ahead and face up again, sir. So let's say it's P, R, L, we not L. C. Let's go C3 this time. So let's go high. So I'm not here anymore. I'm right here. What's the tissue pool?
Is it a push? It's a push to the spinous, isn't it?
Because it's gone this way, so we can go onto it like that.
Yeah.
Then we contact it. Go this way. Now I'm a little bit lower, and I go this way. Because I'm just pushing the spinous back with me.
And so what listing was that?
That was a PR C3.
C3PR.
Yeah.
Contact point is
Still this. Cervical good. Thoracic. Have you done anterior thoracics?
No.
So we're not going there.
You can teach us.
So we're going to go to the prone. We did diversify. No, we did cross pisiform, single hand contact.
We did the prone, sir?
Can we flip him over and do the prone cervicals?
Face down. It's just the same, but okay. Let's start. So let's do a what? A P. If I'm standing on this side, I'm doing a prone cervical. What am I? What is the listing on? Maybe C6.
It's PL if you're on the right.
So the spinous is moved this way. Where do I stand?
On the other side.
If the spinous is moved this way, I stand where? Because I want to use what? Like the FVJ. But if, so I just think that I'm going to be that side.
Okay.
What's my contact?
No, go ahead. I'll
Let's
move
do
the
it
camera
this way
around.
So that you can,
Sure.
if you're recording. Let's say the spinous is moved that side, okay?
All right.
So I find it, and what do I do? And then what do I tell it?
Look away.
And I don't move. And then I stabilize, and then
You lift the chin first.
just a little bit, yeah. There we are. And then
Pow.
I let it go. What am I doing? I'm
Break it.
pushing this thing this way, okay? So if this way, I should do this.
On the table. Remember, we didn't have these.
That was Lampin junction. That's the concept. You know? And the spinous was gone that side.
I think about the supine thing. The
So my contact was this, and I did
atlas, you
this.
step around catty corner, right?
Yeah.
And then to the shoulder, and then if it's lower, you step around
So
more.
LPJ opposite
back
sides
more
minus,
that way.
we're staying on the same side.
See from you is that you're setting the patient right up to here. So if you're doing a push move, then the spinous should be what? Should be
Up, facing you.
should be up. If you're doing a push move, and you're going to, depends on what you're going to do, but for him it's easy. This is, what are this? Where am I right now?
L4,
SI.
L3. Are you at the SIs right now?
Yeah, this is SI joint, that's SI joint.
L4.
So I'm right here. If I'm doing a spinous contact, I want to see you set on it there. So you're on it. Some people say that, some people say, I don't want this. That's talking to the
That's
patient
Dr.
too
Fail.
much. Don't talk to the patient too much. This is very uncomfortable. I want to see maybe of this.
You need to watch the video I have.
And then, where does this go?
Up.
Hip to hip.
No, I'm not kicking.
Hip to hip.
Hip to hip.
Hip to
Lay
hip.
your
so-
leg on his leg.
And then,
There you go.
you should be able to move it.
That would be far.
If it's a kick move,
Push.
All the spinals.
if
Is
it's a
that-
kick move,
Is that a,
spinous contact,
Those are for
same.
pulls. You pull.
That, this stabilizes here, this comes here, now we are here, and what we don't do.
And that would be like a PL.
that's a PL.
Yes, now the spinals will be facing, the spinals will be down.
Okay.
Now, what about the LPJ? I mean, the
Want me to
TP.
adjust
I mean, the mammillary contact.
Any more words you'd like to use?
Yeah, I know, right? Jesus.
So, that's the push and the pull. What about
I can't
here?
remember
You've
which
done the
side is
pelvic,
up
have
and
you?
down.
High TP's up.
Yeah, you've got all, so you
Is
can't
it?
contact that.
Mammillary
So, pull,
So if it was a P, yeah, you do a PL.
the spinous is facing down, push, the spinous is facing up, so you're doing this, and you're doing
I
this.
believe.
Now, you can also contact the mammillary, the mammillary
Yeah.
process. And that way,
It would be a PL, right?
and how much do I rotate here?
Man, I hope it's a PR.
Or do you want to be on the side of that?
So I need to be on top of this, so if,
Yeah.
Yeah, PL, right?
PL, yes.
Oh, it was.
And how much do I rotate here?
I don't know if we ever talked about the amount.
Do I rotate the amount? But I'm not going to
We
the
rotate
spine.
them more than if we were doing a spinous.
Correct, and you're going to the mammillary process. So
Rotate them more towards it.
if, yeah, you bring more towards you, and then this is really what you want. Because it's still P to A.
I miss your hands.
So you have to think P to A this way, P to A this way.
And so,
the spine or 45 degrees?
When you're contacting the spinous process, this is your hand. If you're contacting the mammillary process, this is your hand.
so this is a PL, man.
So this is spinous process,
Yes.
this is,
Yeah, don't get, I was flipped backwards
I don't know,
too.
me too. For some reason, I thought it was the other way.
That's a good name.
Well, I'm
Any
looking
other
here,
concern?
trying to transition to him. Did we do seated chair already? All
are we
right.
ready for tomorrow?
No.
Can we practice tomorrow?
I think we need to practice
We need
tomorrow.
some
So we
time.
practice tomorrow?